does bring us really kind of time-wise on to the final presentation as we had planned. We've got another hour to spend with all of you, and the individual that will be spending that time is joining us from the Cleveland Clinic. It is Luke Williams that comes on board here. A little bit of background on Luke as he opens up his video camera and gets that audio unmuted as well. But Luke's going to be taking us through some content about driveline management. He received his bachelor's degree in nursing from Excelsior College, master in science in nursing, and as an acute care nurse practitioner from Case Western University. He has experience out there as a paramedic as well as being a firefighter in the past, experience in cardiothoracic ICU, emergency, as well as flight nursing, and currently, again, the acute care nurse practitioner at Cleveland Clinic in Cleveland, Ohio. Same thing goes, folks, as the other presentations here today. You're going to get some slides that Luke's going to be walking us all through. If you have questions throughout his presentation, feel free to get those in. I'll either mix them in if appropriate, or Luke, what we'll do is we can hang on to those and maybe last 5 or 10 minutes of our time we'll do a Q&A. But with that, sir, let me welcome you to our event. Thank you for batting cleanup here today, and I'll turn things over to you.
Yeah, thank you very much. Thanks for having me. Thanks for the introduction. Again, my name is Luke Williams. I'm one of the acute care nurse practitioners here in beautiful, sunny Cleveland, Ohio. And I have to say beautiful and sunny because contrary to popular belief, we don't get many days like that out of the year. So we are very appreciative when it comes. I also want to thank Abbott for having me come and speak. I want to thank Louise, our rep, who's also very great and always there for us. And then also all of you that are out there who share a common interest in taking care of all of our bad patients. It's a very difficult job to do, and especially in the past year and a half with the pandemic. So I just wanted to say thank you to everyone out there. So I want to start off with some good news. The good news is I have been told that they are going to be coming out with a total implantable LVAD, but it's going to be after the Cleveland Browns win the Super Bowl. And the bad news is the Browns are likely not to win the Super Bowl for the next 25 to 50 years. So we are going to have a little bit of time to wait for that. One disclosure, I am a Pittsburgh Steelers fan, and one of the best things about living in Cleveland is every time football season rolls around, I historically feel better about my life. So that's one of the good things. Other disclosures, obviously I am here talking on behalf of Abbott. My views, my beliefs, my opinions do not represent Abbott or the Cleveland Clinic at all. All right, so we're going to go through some objectives here. I designed the slides I don't have a lot of statistics. I don't necessarily tend to read from the slides. I kind of have a discussion like I would with anybody else. So we're going to go through some of the background of driveline infections. How do you define the infections, the pathophysiology, the causes, the workup, the treatment, prevention, and then how we approach it from a multidisciplinary team approach. So I want to start off by giving just a little bit of context about our program here at the Cleveland Clinic so you can kind of tell where I'm coming from during this presentation. So over the past 3 years or so, we've implanted approximately 100 LVADs a year. Predominantly, those have been HeartMate 3s over the past 3 years. We have a total of upwards of 300 outpatients, and that's also a mixture of HeartMate 3s, HeartMate 2s, and the HVAD, God rest his soul. We have approximately, as an outpatient, about 1,400 to 1,600 visits a year in the outpatient. Our team consists of 8 nurse practitioners. We have 1 PA, 3 nurses, and an equipment tech. We also have a general manager that oversees us as well. And we work very closely with our heart failure cardiologist and our surgeons, which we have 4 main implanting surgeons. And they are the same ones that will evaluate the imaging of the drive lines and will do the INDs if needed. So I just want to give you a little bit of context about the program. We handle the pre-op education, we handle all the post-op, and then, like I mentioned, we do run a outpatient department as well. So a little bit of background about driveline infections, and if you look at a lot of the research, there's a lot out there. A lot of the data is coming from, a lot of the main registries, the INTERMAX, EuroMax, the IMAX. So if you look at a lot of the research, they're going to mention, a host of things. But there's a few things that kind of stand out when you're looking at drive lines in the course of drive lines. For one is the duration of the device. So obviously, whatever reason you're implanting these devices, whether it's bridge of transplant or destination, most recently there seems to be a progression of, given a variety of factors, the patients are waiting longer and longer, at least the bridge patients, to organ transplant. And as we know that anytime, again, you have any kind of foreign material or especially a foreign body sticking out of the skin or implanted in the skin, the longer that device is in, the more chances you're going to have of developing an infection there. At least at our program, we're kind of split, maybe even a little bit more as the amount of DTs that we implant a year. And again, when you look at the research, and if you even pay close attention to the people that are bridge versus destination, there's a wide variety of reasons that they may be destination. And some of those factors may play into why maybe they are more prone to get driveline infections down the road. I mentioned the transplant wait times, some things that's, obviously out of our control. And then if you look at the literature, it's sometimes what research study you're reading, there's a wide variety of what pumps they did the data on. So recently, as these pumps progress, they're getting smaller. They're making the pump pockets a lot smaller. Surgical technique is improving. So you're having these smaller pumps, which is beneficial, and hopefully the size will continue to go in the opposite direction, or at least the smaller direction, and have the same efficiency and not have the thrombotic risk or the hemolysis risk. But a lot of things have changed over the course of the pumps. The designs have changed. The thrombotic risk has gotten better, the stroke risk. But one thing that obviously, as you guys know who deal with these drive lines, is these driveline infections have persisted over time. And again, the driveline infections, as you guys are well aware of, that work in the VAD community and take care of these patients, they really do disrupt not only just the clinical aspect of the patient, but the quality of life. You're talking about, for some patients, multiple readmissions, outpatient antibiotics, long stays in the hospital, surgical debridements, fatigue, pain, and it really stresses not only the patient, but sometimes, depending on how many readmissions you get, you're using a lot of resources and time. It stresses us out as VAD coordinators as well. So as you read the research, you'll come up with some definitions of infections. The ISHLT definitions are basically 3 categories of the VAD infections. They're going to break it down. Is this a VAD, really VAD-specific infection? Is this somewhat of a related infection? Do you have a primary or secondary VAD-related infections, endocarditis, mediastinitis? And then do you come in with a basically non-VAD-related infection, pneumonia, urinary tract infection, et cetera? So VAD-specific infections, here's where they're going to be talking about basically related to the pump. So is this infection happening somewhere inside of the pump, in the cannulas? Is it around the pump pocket? Or is it extended into the drive line? And these infections, as you will see, a lot of the literature will say that, they start even as early as intra-op. But some of these infections and some of the way, people have dealt with infections in the past, there is some credence to say that, a lot of your risk factors, and even some of these infections, or setting the stage for some of these infections, happen well before the implanting time in the operating room. And that's for a variety of reasons. And then you also hear terms thrown around as proven, probable, or possible. So when we're talking about it, they're talking about mainly, where is the driveline infection located? Is this more of a superficial driveline infection, or is this a deeper infection? And we'll get to a little bit of that later. And then they're also mentioned, what organism, the microbiology of the infection, what radiographic appearances are you seeing with whatever modality that you guys are used to using. And then there's also clinical criteria that will go along with that. So when they speak about proven VAD infections, this is where we're looking at any kind of intraoperative culture samples. It's kind of obviously like many centers, it's routine if they're going for a surgical IND that we want to get good intra-op cultures. That gives us the ability to upgrade these people on their transplant status if they are bridge. And that also includes any kind of needle aspiration of fluid that you may get. So probable and possible VAD infections, those are ones that are going to be diagnosed mainly off of kind of your clinical assessment of the patient. So superficial drive lines, or are they deep infections? So when they classify these superficial infections, they're basically going to say a superficial infection, and it makes sense, is anything outside the fascia and the muscle layers. Now, we do see quite frequently that these infections are very persistent, and depending on what organism you have, may be more persistent than others. And we do see that they certainly can progress over time, and then they turn into what they will classify as these deep infections. And deep infections are basically going to be, as you would guess, anything that's going to be beyond the definition of a superficial. So the other bad thing is these people are also more likely to develop bacteremia, and frequently have reoccurrence of bacteremia, sometimes even on co-pat IV antibiotics. And the bacteremia, again, outside of just, the actual infection, can obviously have, detrimental effects systemically to the patient as well. We've had a few patients that have had pretty significant bacterial infections, and given the design of the pump, again, you have a continuous flow pump. We do know that the architecture of the vascular does change with the continuous flow of the pump. We also know that bacteremia has a chance to cause myocardic aneurysms, so you can get complications that arise from that. And that's only one of many of the complications that can come. So this picture, basically, I'll be honest, we don't usually stage our driveline infections like a lot of the literature has about staging, but this is one example. There are, numerous charts and scales out there that will basically tell you how to stage these driveline infections, and this is one example. There are numerous ones that you can find online, or maybe even you guys use one in your own setting. These are just a few pictures of what a common driveline infection would look like. More than likely, these would be classified somewhere around a 3 or a 4, probably some discrepancy on who's exactly doing the evaluation and how they would grade it. So once we get into the pathophysiology, the infections, so like I said, for any kind of bacteria, they can be very persistent. A lot of times patients will ask me, if I just take these antibiotics, then I'll be free of this infection. And I wish that was so, but, obviously what we find and what some of the literature and a lot of the literature will tell you is, once you start to get these infections in there, it's likely not being able to get them cleared. And the only definitive sometimes treatment to get that infection out of there is removal of all the hardware. And that makes sense. It goes for, other areas outside of the VAD world. It goes for pacemakers. It goes for any kind of infected joints and prosthetic material that you have in you. But the bacteria is very persistent, and it's very persistent, and it's very, lack of a better word, very smart at deceiving us and deceiving what we're throwing at it. So you do get this inoculation of surfaces. We often focus on, the INR levels and, getting the blood not too thick or too thin, just so it has a good interaction with the pump and its surfaces. We worry about the hemolysis of the pump, but there is a lot of inoculation that can happen, on the surfaces of these pumps. And depending on what organism you have, some of the organisms are more robust to adhering to prosthetic surfaces. And then you can get a lot of colony proliferation. And when I say the bacteria are, lack of a better word, smart, it is fascinating if you really dig into the research, read about some of the physiology of how these organisms can form this kind of biofilm. And having this biofilm is basically what they're doing is they're sheltering themselves up in a basement and weathering out a storm. So everything that we're trying to throw at them to, temper these infections down and to limit them, they're forming this little cocoon, and they have this ability to kind of turn on their genes. They can slow their metabolism way down. So once you are hitting them with antibiotics, they can actually kind of just weather the storm through that And then after the antibiotics, so at least the heavy hitters are gone, they can start to proliferate again. And sometimes some of these infections, and again, and it plays into some of the risk factors we'll talk about, to get these antibiotics to, the right place of action, it depends on having to a good port, at least good perfusion there and getting these things actively in there. And sometimes, depending on where the infection's at, it's very hard to, have a good impact on these infections. So we talk about the microbiology. We're mainly going to be talking about bacteria. And again, one thing that hasn't changed along with the driveline infections is, the pathogens, I guess thankfully have been pretty consistent over time. Bacteria is what we're predominantly going to be talking about. It's obviously dominant in early and late infections, and any kind of fungal infection, thank God, is less prevalent. There's some sobering, research to read about fungal infections and how very hard they are to get rid of them or even temper them down, and your mortality will go up higher than having a bacterial infection if you do start to get a fungal infection. And especially if you get fungemia, your mortality goes up drastically. There has been an increase in, like other specialties see, there has been an increase in vancomycin resistant and other multi-drug resistant organisms. So that is worrisome, but thankfully right now, at least what we're seeing, the pathogens have been pretty consistent over time. So when we talk about the bacteria, they're mainly going to be split into, takes you back to pathophysiology class, these gram-negative and gram-positive. The gram-positive, as you can imagine, are going to be more basically like the skin organisms, the Staph aureus, the Staph epi. And then you're going to move into kind of the gram-negative infections. And I'm not sure if, and maybe someone else can answer at some point, if everyone has kind of they're seeing the same kind of predominance in infections as far as the gram-negatives. Lately, it seems like we have a lot more Pseudomonas than anything, but there are a handful of patients that will present with Klebsiella or Enterobacter as well. And then, fungal infections, like I said, thank God they're uncommon, but they do have a higher mortality. Extremely difficult to, I wouldn't even say eradicate, but even just to control sometimes to a great degree. And then the predominant one, at least we see, and at least the research will note, is Candida albicans as well. So risk factors, there is a lot of risk factors in the research. And if you look at the groups, or if you look at the specific risk factors on this page here, a lot of our bridge patients will have a few of these risk factors, and some of our DT patients may have a pretty good amount of these risk factors, coming into the operation or even forming them down the road. Older age is referenced in some literature. In other literature, you'll find that younger age is referenced, mainly, I think, because younger age may have to do with their more active, more movement, more chance of trauma to the driveline, and things like that. Diabetes, likely in your program, like our program, you do see a lot of people who have, are on insulin coming in, either insulin or at least some other kind of oral anti-diabetic agent. Their hemoglobin A1Cs hopefully will stay stable, but sometimes they even elevate over the course of having their device. Renal failure, which is, again, a risk factor. It's very hard, not only dealing with driveline infections or basic LVAD. If you have somebody that requires dialysis, we have real issues here, especially if they need placement in skilled facilities, to find a skilled facility that will take an LVAD and a dialysis patient. Another risk factor, greater severity of heart failure, malnutrition. If you look at, a lot of our patients that come in, if you look at their pre-albumin or albumin levels, they're obviously on the lower side. And then there's some pretty good research that mentions getting some decreased immunity or T-cell dysfunction once you have an LVAD placed. Outside of the driveline being a risk factor, if you have have any other kind of indwelling hardware, or especially lines or catheters. And this mainly, at least for us, is kind of the post-op world of when they come out of the units and they still have central lines. But some of these patients will go home with, depending on the renal function, PICC lines or home catheters. And we have had a few of those patients come back in with those lines infected as well. I mentioned kind of the risk factors, or the biofilming organisms. Again, what organism that you are infected with, obesity, and even to some degree, even rapid weight changes, either loss or gain, can be a risk factor. Delayed sternal closure, and again, risk factors, extended hospital stay. We all would like to get our length of stay decreased, and sometimes that's very difficult to do. But, just like anywhere, the longer you are in a hospital surrounded by healthcare workers and sick people, the more chances you're going to have to pick up something. And then the duration of VAD implant. Like I mentioned, whether you're, bridge to transplant or destination, the times for organ transplant are getting longer. And as far as the ability to get these patients upgraded on the UNO status, and sometimes, as a provider, I sometimes think it's a little bit unfair about the highest duration or the highest status that we can get some of these patients, given how sick they are and the criteria. But we do try our best. And then any kind of trauma to the driveline site. So we'll talk about this a little bit in the H&P, that the history and physical, and any kind of known trauma to the driveline site. And then one of the things that's kind of sometimes not mentioned is, the risk factors, and we've seen this before, is, how's the patient taking care of this driveline? Just like, we do have very compliant patients and we have very non-compliant patients. And then we have a mixture of those that are in the middle. So one of the things that I think is underappreciated is possibly, how these patients are taking care of their drivelines at home. And I think really, when you're looking at these drivelines, or at least when I look at them, I tend to think that there's kind of three core issues here. One, is the design that we're working with. Right now, like I said, we don't have a totally implantable VAD that takes these drivelines away and takes that risk for infection away. So we can't do much about the design. The other thing that plays in, I think it's underappreciated, is more of the human behavior that we have to deal with the patients, and that can be very, very complex at times. And then also, it's all the unknowns that we don't know. And that's one of the good things about the medical field is, you're always learning new things, and things that you thought you knew weren't correct, and you're updating your beliefs, sometimes on a daily or weekly basis, the more you learn. But it's sometimes the unknowns, and you can even use luck. I have patients that come in and I know that they take very meticulous care of their driveline. They do everything right, and they get a very serious driveline infection. And then I have other patients that are, out 3, 4, 5 years, and they're not compliant with other things. I can assume they're not compliant with driveline exit site care, and they have yet to develop a driveline infection. So I think those are kind of like the three core issues, at least in my mind, when we're talking about the issues revolving the driveline infections. So the evaluation of it, again, I kind of break this down into 5 different areas. Observation, the logistics, the lab workup, the imaging modalities, and a kind of a multidisciplinary team approach. And I strongly feel that one of the strong points, at least of our program, and one of the reasons that we have such good success is this multidisciplinary team, which I'll talk about a little bit later. So observation, again, I believe this starts with the patient education. Again, we spend a lot of time with these patients pre-op, going over the device with them, being very, very transparent about what life looks like with the LVAD, and really trying to ingrain in them some of the potential complications that having an LVAD can produce. And we do spend a lot of time, especially with driveline infections, because, again, it's hard to imagine, what a driveline infection would look like or feel like or what's involved. It's in the future. There's not this immediacy to it. We'll have patients that will send us pictures of their drivelines, and it looks pretty bad, that they should kind of be evaluated. And we'll tell them it would be a good idea if you came up to our outpatient clinic in the next couple of days. We'd really like to see you. We don't want this to turn into something more extensive than it appears right now. And patients, some of the patients will say, well, I just don't have time for that. I'm going out of town. I have X, Y, and Z going on. So it's not this immediacy that if a patient calls and they're low flowing and their pump sounds horrible, there's an immediacy to that. People don't recognize that, there is an immediacy to, any kind of infection or brewing infection that you can get in these drivelines, because they just don't have that in their mind. A lot of patients, that there is this immediate need to, have it looked at. They'll push it off, they'll put it off, and before long, they're coming in with a way worse looking driveline than the original picture they sent us. And then it goes back again, how are we educating these patients, not only with the knowledge that they need to have, but also with the skills they need, the tactile or the skills they need to change the driveline and take care of it. And then also having the awareness of the site changes, and all this ability and this knowledge and the awareness is great. But if you don't have a way that your patients can, accurately and in a timely manner communicate these changes, and then you have a process of evaluating these patients, it can fall through the cracks, especially with us when we're tracking close to 300 outpatient LVADs. It can be very challenging at times. Inspection of the exit site, again, these are basic things for any kind of wound that we tell people to, inspect. You want them to observe for any kind of local changes. Are they having pain? Are they having swelling? Is there a lot of redness? Or do they have an increase in drainage? And not just so much as the increase in drainage there. Is the color, is the consistency of the drainage changed? And again, I've seen, people that will present with a driveline infection that on the surface, doesn't look too bad. You may even graded a, stage 1 or 2 off of some of these things. And then you look further in the imaging and it turns out to be more of a deep infection. And then we say, we always ask them, or if we see them in person, how are they presenting? What kind of systemic signs do they have? Are you having fevers? Are you having chills? Are you having, this vague general weakness or just not feeling right? And a lot of our LVAD patients are, pretty in tune with their body and can tell you when something is somewhat not right with them. And then exit site pictures. Again, we have a process to where, and again, this is a process I may talk about later, that where we can improve probably. So we do have the ability of these patients to, get pictures to us. In this day and age, it's very rare to find a person that doesn't have a smartphone or the ability to take a picture and transmit it to us by email or even by text. We also have a process to where they, every time they come into the outpatient for a follow-up visit, during the driveline change, we do take a picture and we do put it in our Epic system as part of the record. But it's funny because, in developing these lectures and looking at some of this stuff, one of the things that we don't do that we probably should do, and I've brought this up, is we usually tell patients when they come in for their outpatient visit that, don't bother changing your driveline that day. Once you come into the outpatient, we will change the driveline because we would like to get a picture of it for our records and then look at it, inspect it ourselves. One of the things that we probably should do, and maybe other programs do this, is instead of having, us change it as providers and doing all the work, that would probably be a good opportunity for us to have some, continuing education or observation exactly how these people are taking care of their drivelines. Because, at least for us, a lot of the education goes on, pre-op, and then post-op is where, once you get out to the floor, is where they start learning the ins and outs of the driveline and the VAD management, and any caregivers. And again, the past year and a half has been a little fluid situation with visitation, but any of the caregivers or people that are going to be primarily involved in the care are learning how to do the driveline management as well. But as we see, and maybe some of you guys see, the plans that are set up pre-op and even post-op, as far as the social situations, we've had them change even the day before, discharge. So-and-so is not going to take care of me. I can't go back here. I don't know who's going to take care of me. So we send these people out with, I guess, with the thought or the confidence that they do know how to change a driveline, but we never really reevaluate if, in fact, they're doing it correctly. So that's one area that we could possibly improve. So part of the evaluation, we're doing a thorough history and physical. We want to know, have they had any recent trauma to the site that they know of? Did they catch it on anything? Were they wearing their anchor? Did they drop the controller? Anything? And a lot of times people report, yeah, I got it caught on something, a week prior, and a couple days ago it started to ooze a little bit more. Any kind of changes in physical activity, are you doing anything out of the ordinary, bending, twisting, doing anything that you don't normally do? And how has your weight been? How has your weight been, since implant? Has it gone up? Has it gone down? Has there been any rapid fluctuations? And then we're talking about any kind of deviations from their process of changing their driveline. Are they doing anything different? Is anybody else different changing it? How frequent are they changing it? And then we're looking at, have you had any unrelated recent illness? Have you been any signs of infection that you went to your primary and got treated for a sinus, what they thought was a sinus infection, any other kind of related illness? And then we also want to know what's the onset and the progression. How many days ago did this start? How are you feeling prior to that? And how, slowly or rapidly, has this progressed that you need to convey this to us or at least bring it to our attention? And then we're also looking at any prior infectious issues. And that's, we're going back through the chart review, looking at some of their, microbiology from before. Is this their first time they're, dealing with this infection? Has this been chronic and ongoing? What microorganisms have they had? Has that been pretty consistent, or has that been changing? And then also looking, through the ID notes and through our notes, what antibiotics have they been on? Are they on, have they recently been treated with IV antibiotics, and which ones, and what organisms were targeted? And, have they been off of antibiotics and for how long? Or are they on, chronic suppressive oral antibiotics at home? So logistics, like I said, we put in about 100 pumps a year. We have about 300 outpatients. So sometimes logistics can play a pretty big role. It would be nice if, every driveline you thought needed a real workup would have the ability to be admitted. But again, what we want to do clinically sometimes doesn't work out with what patients have going on in their lives outside of the driveline. And that could be distance, that could be financial, that could be other psychosocial concerns that they have, why they can't come up and either at least see us an outpatient or even be directly admitted for a workup. So what we need to know is, what our thought process is again, where's the location of the patient? There's nothing better than having a patient has nothing going on who lives in Cleveland, Ohio, who has a ride to the hospital. That's the ideal patient. Again, we're going to look at, where are you guys and how are we going to approach this, what we think is, a potential driveline infection? Is this going to be a local workup? We implant patients from, multiple states who, live in those states, or patients from here that vacation in Florida? Is it possible, and where are you going to, at least get a basic local workup and at least have somebody, some professional lay eyes on this driveline? Are you able to come in for a outpatient VAD clinic appointment? Or do we think it's that bad, and given your history of prior infections and what you're describing, that we're just going to directly admit you as an inpatient and go from there? So when we're looking at local workups, we want to get, like everyone would normally get, labs, cultures. Do we want to start you on empiric antibiotics, targeting what we think is the organism? And again, a trial of a week or two of oral antibiotics and seeing how you're doing. And then what's going to be our follow-up plan? And again, how are we going to make sure we follow up on that follow-up plan so that these patients don't fall through the cracks, and they just get lost in the sea of LVADs that we take care of. And then is it a potential, and it's very hard to get, patients, at least in Ohio, scheduled for outpatient CAT scan imaging as far as insurance. Is there anywhere locally, like the ER, that you could go have somebody lay eyes on you, have your lab work done, and get some imaging, and that imaging could be overnighted up to us for our surgeons to look at. So then you want to determine, what's the setting of the ongoing care. Are we going to just observe this patient at home and just kind of, plan a follow-up appointment down the road, 1 or 2 weeks, or even, in the last year and a half, sometimes patients have been very hesitant to come to the hospital with COVID. We've done a lot of virtual appointments as well. Are we going to manage these patients with some kind of outpatient regimen? And sometimes, given the organism that they've had in the past, there's not a lot of oral good options. And this is where, and I'll talk about this later with our ID colleagues, this is where we reach out to them and saying, this is what's going on. What do you advise, at least for an oral regimen? Because sometimes these infections in the organisms can get pretty complicated, and we depend a lot on the expertise of at least the pharmacology of the antibiotics from our ID colleagues. And then obviously inpatient is anything that we think is going to be a real deep infection, or we suspect is going to be a deep infection, if they're showing any signs of systemic illness. And then, like I said, we're looking at their prior infectious history. If we know, X patient historically presents the same way he's telling me, and he's had multiple debridements, we're probably not going to waste around with an outpatient local evaluation, or even or clog up the outpatient department. We're just going to have them be willing to directly be admitted to our facility for evaluation. So onward with the evaluation. Again, some basic lab work that probably, like you guys, we get. We obviously want to see, what the organism is. What are we treating? Is it the same organism that we have been treating in the past, or now do they have a complementary organism? We do get blood cultures routinely on everybody we do think is infected. We do get blood cultures. We also want to know, at least if we're not seeing them directly, do you have a pick in place for any reason that we don't know of, or a hone, or any other indwelling line that we don't know about? Sometimes I do normally get baseline, at least baseline procalcitonins, CRPs, and again, CRPs are not going to be real great, likely post-op, but for the patients that have been out a while, it doesn't hurt to get baseline CRPs and procals. And then you're basically just drawing your basic labs. And then if they look real bad, this moves more in the ICU realm. If they look really bad systemically, ABGs with lactates, and then again, other cultures guided by what they're presenting with. So imaging, everyone that we suspect that has a driveline infection, we predominantly do non-contrast CTs of the chest, abdomen, at least CTs of the abdomen for sure. We will do the chest given if they have a significant history. And all of those scans, we work, like I said, very closely with, we have 4 main surgeons. They all individually review the scans, and then we have a discussion also with the infectious disease. So anybody that comes in, at least inpatient, and sometimes outpatient, but at least inpatient, we do image them, and we do consult our ID colleagues. And we have approximately 4 infectious disease dedicated specialists that work mainly with our LVAD population. So that is convenient because they talk amongst each other, and there's a good flow of information from our team to theirs. We have been doing more and more PET scans. And then given the situation or how they're presenting, we may determine that they need more than just a surface echo, especially if they're having persistent bacteremia that we think might be coming potentially if they have an ICD from some other source. If it's a persistent bacteremia, we may go ahead and get a TEE on these patients. And we also, we ask them, which is sometimes overlooked, about their dental history. We've had quite a few patients that have either gone to the dentist recently, had some dental work done, or chipped a tooth, have a little bit of pain, but didn't really take notice of it. And then we have our dental colleagues kind of look at them and they have some kind of abscess forming in there. So that's one of the things, when I first kind of started working with the VADs, I'll be honest, I kind of overlooked, but through my mistakes and the way people have presented, it's pretty ingrained in me to ask about any kind of dental issues that may be going on. And again, basic treatment here, how systemically ill do they look? And that's going to determine, for one, if you're admitting them inpatient, where these patients are going to go. At our facility, we have dedicated units for our LVAD patients. We have a heart failure dedicated ICU that they can go to, and we also have our post-op cardiothoracic ICU that they can go to. But do they need ICU support? Do they need more things? Because it's frustrating to have a patient be admitted inpatient and then all of a sudden realize that they're going to need a lot more support, and then you have to transfer them back over to the ICU. And then we're talking about looking at their renal function. A lot of these patients, again, even pre-op had some degree of CKD. So we wanted to see what their renal function's doing. And again, we work closely with our ID specialists and even our pharmacists. We have some dedicated pharmacists that are specifically dedicated towards our heart failure teams and VAD teams that we work with as far as, dosing these antibiotics correctly. And then you're always looking at the heart failure aspect of anybody that comes in with an infection, at least from an LVAD perspective. And then we're thinking about do we anticipate a need for a surgical intervention, and what's going to be the timing of that surgical intervention? So working with our surgeons and their schedules, and then do we need to hold the Coumadin when these patients come in because we're anticipating something that may or may not happen. So getting a feel historically for what they've had done and what we anticipate they may need. And then other things, basic heart failure management. Most of these patients do not come in with just heart failure. They have other chronic diseases that we are, may be driving some of the complications associated with these drivelines. And then, symptom management. And then I'm also looking at what is, in fact, your transplant status if you are a bridge. Are you, in fact, too sick right now and you should be made a status 7? Are you a status 4? And if we do decide to do a IND, can you get upgraded to a status 3? Or is there some issue to where we can get a status 2 by exemption for you for a certain amount of time? So discussing that with our transplant colleagues and having them kind of weed through all the criteria is beneficial as well. Antibiotics, going to be the mainstay of treatment. Are we going to do empiric or directed? It seems like, everyone gets vitamin V and vitamin Z when they come into the hospital. They initially get placed, on the vancomycin until our ID colleagues say, no, we can get rid of those, or we can substitute one for the other, or we think it's just this. Why don't you just get rid of the Zosyn and treat with the vanc? And then depending, again, on the logistics of it, obviously you're not doing IV antibiotics as a distance or an outpatient. So what oral regimen are you going to choose and for how long? Mainly anybody that comes in inpatient. I have yet to give anybody started off with oral antibiotics. It's always just been IV for 24 hours until, again, the ID colleagues see them and kind of can guide us towards the best option for them. And then where do we presume, or where can we find out where the infection's coming from? Are we dealing with a superficial infection? Are we dealing with a deep? Is it in the blood? And I went over prior known organisms. What have they had before? Is this what we presume they have again? Have they been on these antibiotics inpatient and, they're actually getting worse, they're not getting better? Are we dealing with some other organism that we haven't found that is different from the one we're treating? And then how quickly can we de-escalate? Again, for the VAD population and how these VAD infections can really escalate and get out of hand in a shorter period of time. you really want to make sure that, as opposed to other areas, that I work in, I work a lot of pulmonary critical care as well on the side, and antibiotics historically are overprescribed, but you really want to make sure that you're de-escalating the timing of it, and also what you're de-escalating to is appropriate. And then how long are these patients going to be on therapy? Like I said, a decent trial of 2 weeks as an outpatient, I think is, acceptable. Inpatient, again, guided by our ID colleagues, we're going to have patients that, they may require just IV antibiotics during their stay, and then we switch them over to some oral regimen. Other people, at least historically, people that come in and get surgical INDs, more times than not, they will get a PIC or a home place, and they will go home on 6 weeks of antibiotics. And then at that time, the day that their antibiotics are up is when we set them to come back in for an outpatient visit between us, and a joint visit between us and ID. And then we determine the plan going forward. Can we pull the PIC line or hone? Can we transition them off of antibiotics, or do we think that they need to be on continuous oral suppressive antibiotics? And then also, what is their response to therapy? Again, we discuss mainly with our cardiothoracic surgeons. There is some debate about source control. If you talk to some surgeons, their last resort sometimes will be doing an IND. Other ones will want to gain source control by getting in there, draining out as much as they can. The bad part is a lot of these patients come out with a wound vac, which is just another resource that we have to set up and they have to manage at home. Any inpatient that gets a wound vac, we do have a dedicated ostomy team, wound vac team that will come and assist with us changing them as well. Then we want to make sure that they don't have any ICD or any other kind of valve involvement. There's some literature that will say, if you compare INDs and antibiotics to just IV antibiotics alone, you can get reoccurrence of just antibiotics alone. And again, like I mentioned, the definitive cure is complete removal of the hardware, which may, hopefully for our bridge patients, means transplant. Again, deep infections, they can be very persistent. Even superficial infections can be very persistent as well. Some conflicting data on whether suppressive antibiotics are beneficial or not. We rely heavily on our ID colleagues across the spectrum of care, inpatient, outpatient, even questions when the patients call up to us. We sometimes reach out to our ID colleagues and say, hey, what would you do in this situation? And then, do they have any device seeding or any kind of endovascular infection that we need to consider if they're having persistent bloodstream infections? Really no good data, at least that I found, that's going to support the duration of antibiotics after you exchange the device or transplant. I haven't really found any good data. I'm not really sure what other institutions are doing for that situation. And I did talk about, I alluded to our multidisciplinary approach, which I think is the mainstay. We do have our primary VAD team, which is the primary providers. We do interact closely with all of these people, which I think really helps. We have our cardiothoracic surgeons, our ID specialists, our pharmacists are fantastic. They're very knowledgeable, and we reach out to them for a lot of things. An overlooked part, our case managers and social work, handling, setting up IV antibiotics, the wound vac, the home care, and even our social workers talking about all the other things that come along, psychosocial, from having driveline infections. Our wound team assists us, and then all the other people, the floor RNs and all the other ancillary support are basically, our mainstay of our team. And then also the patient and the family, depending on who the caregivers were at home, how these bloodstream or these driveline infections can be very persistent, and they can affect the quality of life of the patient. Constant readmissions, generalized just not feeling well. They can have, financial issues from dealing with these things, a lot of mental health issues I've seen some people have. So really paying attention to how the patient and family are coping and what resources we can get to them. Prevention. So prevention, have we found or do we know of any, pre-op infections that need to be adequately treated before these patients go to the OR? We do know that, some viable bacteria do remain, even with the pre-op cleaning, the normal skin cleaning. We do know that the deep layers of the skin, that there are these organisms that still persist. Obviously, the clipping of the hair, avoiding the shaving, and then sending, at least PCRA to the nares for MRSA. And I did read some research that people are doing some preem sites for VRE and different kind of organisms there, but we currently do not do that. And then you need to expect some inoculation of bacteria in the surgical wounds and pump components, no matter how sterile, I guess, the field we think it is. Routine prophylactic antibiotics, usually for the post 24 to 48 hours, are routine for our VAD patients. Surgeons, and again, this is institution, by institution it varies. We do soak the Driveline pre-op in rifampin as well. And then surgical technique, which has been refined over the years, and how are the surgeons tunneling the Driveline to give the most protection of, distance and most protection between the exit site of that Driveline all the way up to at least a pump pocket. And then looking at the velour on the Drivelines when we see them, at least when they're coming in for outpatient or even inpatient, just noticing is anything changed, observationally about what the Driveline looks like as it exits the skin. Post-op, like I mentioned, continued use of antibiotics, usually not longer than 48 hours, getting them out of the ICU, getting all the tubes. There's a lot of times that patients will come out historically with Foley still in. It's, you have to explain to the patients why you want to get all these things out. So removal of, all lines or tubes is, can only be beneficial if they truly don't need it. Blood glucose control, again, on the long end, short end and long end, if you can get that more tightly controlled. And then continued monitor of the Driveline exit site and how are we going to immobilize this, and that really starts immediately post-op day 0 after they come out of the OR, making sure that the ICU nurses are knowledgeable and the Foley anchors and being compliant with that. And then also starting to educate the patient on, once they start to get up and move post-op, to be mindful that you do now have, and most people are mindful that they have an LVAD, but they also need to be aware that, it does get some taking used to, that you do have a, Driveline that's coming out and you can't get it snagged or caught or stuck on things. Prevention, ongoing Driveline education. We certainly have room for improvement on this, on how we're going to do the ongoing education. Right now, I sometimes feel like it's, you compare it to getting your driver's license, where you do all this knowledge and you get tested once, and then, at least in Ohio, I've never been tested again if I know how to drive a car. Hands-on proficiency, having these people and ingraining this in the floor nurses that, as soon as they need to start doing hands-on, telling people about the Driveline and giving them, information packets and knowledge about the Driveline. You really need to incorporate the hands-on proficiency, and we need to make sure that we are confident by the time of discharge that they are proficient in changing this Driveline, or their caregiver is. And we need to know if that environment situation has changed and the person that's doing the Driveline has never received any training at all. But we, like I said, certainly have ways to expand on that and evaluating patients across the continuum once they have their LVAD. Routine follow-up, obviously the more we can, see our patients, the more the patients can grasp how serious a Driveline infection can be and the knowledge of what to look for and how to communicate that. And it all goes into kind of early recognition is key. Again, we might not be able to completely, eradicate these organisms, but the sooner we can hop on your initial insult, I got to believe the better off down the road you're going to be. Future real quick, again, the total implantable pump. Brown's got to win the Super Bowl though, so don't hold your breath. The allocation system, again, trying to get these patients upgraded with their status, and how long some of our patients are waiting on the system for organs. So you're going to see a lot as we implant more and more LVADs, and no matter what your, if you're bridge or destination, you're going to be spending a lot more time with the chance of developing an infection. And then, standardizing a driveline changing protocol. It'd be nice if somehow we can figure out what's the best way to do this. Currently, what our protocol is we have the patients change their drivelines once a day until we are confident that there's a lot of ingrowth and the site looks good, and then we change them to twice a week. I have commented, I'm, again, not sure if this is the best practice or not, because you're basically taking a standardized change it once a day and you're extrapolating it to, patients that are very heterogeneous. Like I would be confident in some of our patients that they could change it once a day and have no issues. Other patients, they don't even, some of them can barely tie their shoes. And the last thing I want is for them to be mucking around with their sterile environment, especially when they have a chance to do it wrong, multiple, 7 days a week. So maybe moving away from that to more of a guided, depending on the patient. And is there ways to permit better healing and ingrowth? Can we take ways that away from other services and what other people are doing for other kinds of wounds and help that? And then unfortunately, and hopefully the bacteria and organisms have stayed pretty persistent over time. But again, there's always a chance that more multi-drug resistant organisms will pop up, and we'll have to deal with that in the best way we can. That's it. I want to say thank you. It's been a pleasure. I appreciate you guys letting me speak, and yeah, it's nice to interact with all the colleagues that are out there across the nation. So I appreciate it.